Hi, and welcome to our next edition of our Complete Physio podcast. And I'm delighted to welcome with me today's guest, which is Dr. Matteo Bernardotto, and who has recently set up an amazing new service with Complete Physio Injections. So I'll just let Matteo tell you a little bit about that.
Hi, good morning. Thanks, Dave, and thank you for inviting me to talk about this. I'm Matteo Bernardotto. I'm a sport and musculoskeletal medicine consultant. Do a bit of work in the NHS at University College London and privately as well. And I'm really happy to have recently helped set up the ultrasound guided spinal injection clinic at Complete Physio.
Brilliant. Okay, and just got a few sort of questions that we're going to sort of run through today, just to really sort of help patients really understand a bit more about this service and how it works. And I guess most importantly, what these particular injections can be sort of useful for. So I'm going to kick off by asking. So I'm a patient. How would I know if this treatment is right for me, or if this is the appropriate treatment for me? So who's your target audience, I guess?
Okay. I guess there's lots of different indications for spinal injections. It's it's a wide area, so not everyone will be requiring that, but predominantly we're looking at patients with back or neck pain or pain that refers away from the back, such as sciatica, so pain going to the leg, or pain radiating from the neck to the arm or the hand. So those are the main patients that we are considering for injection. Again, not all of them will be needing them, and it's typically those patients that have already been assessed by a physiotherapist or a doctor, have started a course of physiotherapy and an exercise program, and are not improving with their pain. So those are predominantly the patients that may benefit from an injection.
Excellent. And so I guess if we just said, the number one, if I'm a patient and I'm sort of thinking about possibly looking to have this treatment, would you say sort of having pain around the back, or is it more appropriate if I'm experiencing more sort of like leg symptoms? What's the sort of number one factor that you would say that you would be looking for?
Back pain will definitely be a key feature in a patient's symptoms. Often it's associated with sciatica or pain shooting down the leg or the foot, sometimes with alteration in sensation, so you get numbness, pins and needles, or burning. But you have to bear in mind that there are so many different types of spinal injections that you can do. So it's really a matter of exploring the patient's symptoms individually and see what type of injection could provide them some relief. There's not one type only, so it needs to be individualized to the patient.
Excellent. And just in terms of how patients sort of navigate to your clinic, so is it generally, would you say, is more patients self-referring, or do you get referrals from sort of physios, osteopaths, chiropractors, or even from medical colleagues? So what is the normal route into your clinic, would you say?
It's a mix, really. So many patients, come because they've already seen a medical specialist, whether it's a doctor, or a physiotherapist, or an osteopath, and they've failed to progress with their condition, and their pain still remains a problem. So those patients often get referred to me for a second opinion and for consideration of an injection. Equally, some patients seek an injection independently, even though in a lot of cases, even with self-referrals, they've already done some self-treatment or sought some treatment options themselves, whether it's massage, or medications through their GP, etc.
Excellent. And obviously, whenever we're thinking about injections anywhere in the body, I guess, but certainly if someone's contemplating about having an injection somewhere around their back or around their spine, obviously safety is a big factor. We just talk a little bit about the sort of like the safety of these procedures.
Yeah. So You're very right. And the safety is paramount whenever you plan an injection, particularly when you're planning an injection in and around the spine. Like with all medical interventions and procedures, there's a protocol and a safety checklist that you need to follow to make sure that the procedure is done for the right indications, so for the right patient, and it's not done unnecessarily. So that's number one. So selection of the patient, and then secondly, making sure that all the basic safeguards are in place. So infection control, so using sterile equipment, sterilization of the area you're injecting, and technique. So some of those injections can be challenging, and it's important that they are done by a doctor that is experiencing this field and has done many of them, and it's got a good track record of positive clinical outcomes.
Great. And you do the spinal injections under ultrasound guidance, which I know, many people, that's slightly unusual or relatively new thing. Can you just tell us a little bit about the history of spinal injections under ultrasound guidance and how it compares with other techniques that are used in the UK?
Yes, that's very interesting questions, and you're right. Ultrasound guided spinal injection is a relatively new technique, particularly in the UK. As you know, ultrasound and ultrasound guided injections for arms and legs and different joints around the body have been around for decades in the UK and around the world. However, in the spine, it's a relatively new field. However, in some countries, particularly Germany, Austria, South Korea, ultrasound-guided spinal injections have been around and an established modality for many, many years. And in fact, a lot of studies already show that the outcomes you get from ultrasound-guided procedures are equivalent to those you get using more traditional modalities, which is usually fluoroscopy, so X-ray guided injections, or CT guided injections. The limiting factor in the UK is that there's not many people trained in these techniques. Myself, I went to Austria to train in ultrasound guided spinal injections for a fellowship some years back, and I was able to bring this technique back in both my NHS clinic and in my private practice. So it's a new technique, but it's got a lot of advantages, and it's something that will probably become more and more commonplace and standardized as time goes by.
Okay. Can you tell us a little bit about some of the advantages of having these procedures done under ultrasound versus other ways of performing them?
Yeah, of course. I mean, the main advantage of ultrasound scan is that the injection can be provided point of care. That means that in your clinic, when you see the patient, take the history, examine them, you can at the same time provide an ultrasound scan and an injection there and then. So you can provide a potentially pain relieving procedure almost immediately, which is much more convenient and efficient for the patient. And as a result of that, is also much more cost effective, because you all of a sudden don't rely on the huge infrastructure, for example, surgical theaters for X-ray guided injections, or a CT scanner suite that you need for CT guided injections, where you have doctors, radiologists, radiographers, and different nursing staff to support you. With ultrasound guidance, you can provide the injection point of care and in your outpatient clinic. The other really key advantage of ultrasound guided injection is that it doesn't come with radiation. So it's much more safe for patients. Remember, with X-ray and CT guided in particular, there's a lot of radiation that the patient is exposed to whilst they're having the procedure, which is something that, if possible, we should avoid.
Excellent. So just to clarify as well for potential patients and referrers, the ultrasound that you do at the time of the injections, that isn't for diagnostics so much, is it? That's for guiding the procedure. Am I right in saying that?
You're 100% right. And in fact, I highlighted the positives of ultrasound scan. It's also important to be clear about some of the limitations. So ultrasound in the context of spinal injection is purely for intervention. So it's purely used to deliver the injection. It's not for diagnostics. So it's not to confirm the problem. That is why the vast majority, if not all patients that undergo spinal injections, and this is true whether it's X-ray guided or ultrasound guided, they need to have had prior investigations. This is usually in an MRI scan, which gives you a good anatomical overview of the target area. It makes sure that we don't miss out any underlying serious conditions or pathologies, but also it helps us to confirm whether this or that injection is the right thing to do for the patient.
Excellent. And just to clarify, so for potential patients that are thinking of for this treatment and or referrers, how recently would you have needed them to have had an MRI scan for them to be considered for this treatment?
So there is no clear cutoff point for that, but personally, and a lot of literature supports me that when you plan for a spinal procedure, the imaging, in this case, let's say like an MRI scan, should not be ideally older than 6 months and definitely not older than a year old, because things can evolve and change over the time, and the MRI scans may not accurately reflect anymore what's going on with the patient and their symptoms.
Mm-hmm. And just, if you don't mind just running us through, because you do an amazing range of injections. So if you just mind running us through the range of injections that you're able to offer.
Mm-hmm. Yeah, so there's lots of different options when it comes to spinal injections. So it's really important to be aware of what the options are and what they're for. Predominantly, they can be split into 2 different groups. One are spinal joint injection. These are called facet joints, and they can be delivered to the neck, to the middle back, so the thoracic spine, as well as the lower back. And those are typically for people that have what we call facetogenic pain. What does that mean? It means pain that comes from the joint, and it's typically patients that have got degenerative back or spinal problems like arthritis or an inflammatory arthritis, and their pain is also associated often with decreased range of movement, stiffness, pain when standing for long periods, etc. Although I'm simplifying here. The other main group of injections are nerve root injections. So along the spine, literally from the base of your skull to your lower back, you have nerves that at each level come out and then they supply the sensation and the muscle control in your arms, your legs, and around the body. When those nerves are irritated, for example, by a burning spur or a disc that is bulging, they can cause pain. And typically those situations will give you something like sciatica, very commonly, so pain shooting into the leg or the foot, or brachialgia, pain shooting into the arm or the hand. And with ultrasound, you can target the specific nerve and inject in and around them to try to calm them down and provide some relief. The other group of injections, it's infiltrations. The most commonly used one in the spine is something called a caudal epidural. So caudal epidural is done around the sacrum, so the sitting bone, and it allows us to deliver a high volume and amount of medication to the whole of the sacrum, the sitting area, and the lumbar spine, so the lower back. That sometimes can be a very effective option for people with persistent lower back pain, or when they have stenosis, which is a condition where there is some wear in the lower back and often pain radiates to both legs, either the buttocks, the thighs, the feet, etc. So these are the main groups of injections that you can do under ultrasound guidance. There's lots more very specialist injections, but these are probably the bread and butter ones that I think people should be aware of.
hmm And you do a few injections around the pelvis, sacroiliac joint, and piriformis. Can you tell us a little bit about those? And again, in terms of a patient's thinking, if that might be right for them, sort of key factors that you would look for those type of injections.
Yeah, so I think the pelvis and the hip region is very intimately related with the lower back and the spine, and it's quite common actually for people to present with either back pain, buttock pain, or thigh pain that is not necessarily arising from the back, although that needs to be excluded. It can also arise from different structures in the region. Something that we often explore is whether the pain comes from the sacroiliac joints, which are the joints in your sitting bone, which are can be affected by inflammation or degenerative changes like osteoarthritis, and they can commonly cause pain shooting into the buttock. And the other thing to bear in mind in that region is the muscles deep into the gluteal region, so the buttock muscles. There are some key muscles there that work as stabilizers for the hip joint and the pelvis, like quadratus femoris or piriformis. People may have heard of piriformis syndrome, and those can be quite key targets for patients with persistent gluteal, so buttock pain, which doesn't have a clear structural cause or spinal or back-related cause.
Great. Is there anyone in particular? So if I'm watching this and I'm sort of thinking, am I not appropriate? Is there any particular factors or features or medical conditions that would exclude someone from having this treatment?
I think that there's no absolute contraindications. Again, at the medical assessment before proceeding with a spinal injection, it's important that things are explored. So in my practice, I would always look through the past medical history to make sure that the patient is fit and there are no conditions that may influence the outcome of the injection and its effectiveness. For example, people on anticoagulants or blood thinner medications, they can have the injections, but it's often important to be aware of what kind of medicines they're taking, what they're taking it for, and whether they need to be adjusted in dose or maybe even skipping some of those medications before proceeding with the injections. Other medical conditions to be aware about is, for example, diabetes. In diabetes, there's a slightly higher risk of an infection, also, when you inject steroids in someone with diabetes, whether it's the shoulder or the spine or any other parts of the body, the sugar levels go up for a few weeks after that. So it's important that patients are counseled appropriately before the procedure so that they can manage their sugars accordingly in the following weeks. This is particularly important, for example, if they're on insulin, which needs to be adjusted at every administration.
Excellent. So what would you say if you were just to very briefly sort of take people through what they can expect to actually happen on the day? So when they come along for their appointment, what does that actually look like? What can they expect to experience on the day?
Yeah, that's a very good question, because when a patient turns up for an injection clinic appointment, you don't just rush them onto the bed and do the injection. It takes preparation, and the patient needs to be assessed. So my standard practice is, first of all, to clarify their history, their pain, how it's been behaving, how long it's been there, and all the different factors that have been contributing to it. And it's important to explore their whole history, like I mentioned before, medical conditions, the medications, allergies, etc. But also, and this is key, they need to be clinically examined, because that gives us a lot of information as to what the most appropriate injection may be. And on top of that, you need to factor in the imaging, okay? Because particularly an MRI scan is a very useful tool, but it always provides a lot of information about someone's spine, let's say, and it's really important that we tease out the key findings in those scans and ignore the ones that are, for example, incidental or normal age-related changes. So before we even proceed for an injection, you really need to triangulate the patient's history, their pain, their examination, and the MRI scan findings, because that's really the key to make sure that we select the right patient for the injections and the right procedure for themselves. In terms of what happens for the injection itself, a lot of it is actually preparation. So most spinal injections need to be performed prone. That means the patient lies on their tummy on a bed, and particularly for the lower back, they'll have a pillow in front of the tummy to get rid of the curvature of the lower back. And then once the target area is exposed and the area is cleared, a lot of time is spent scanning, mostly to find the target. Scanning the spine can be quite challenging. There's a lot of different anatomical structures to be aware of. And so a lot of care needs to be taken that in exploring the area and make sure that the target that we want to inject it's confirmed and accurately localized. Once that's the case, like with all injections, it's a matter of reducing infection risk, so sterilizing the area with antiseptic sprays or liquid, cleaning the ultrasound probe, using sterile gloves and all equipment, and with an assistant delivering the medication on target with a needle. That's actually often the quickest part of the whole process, and can sometimes be a bit uncomfortable, but more often than not anticlimactic, because you spend quite a lot of time scanning and then the injection is over in about 10-20 seconds. But that's the real key and advantage of ultrasound scanning. It can be done effectively and time efficiently in your outpatient clinic. After the injection, though, it's important to be mindful and it's important that patients take care of themselves. So normally patients are told to wait at reception and sit down for about 20-30 minutes to make sure they don't feel dizzy and they don't have any immediate side effects or complications, which are rare, but to make sure that they can then go home safe and without any problems.
Excellent. And just in terms, because we always get asked this with all of our injections, that sort of, from the point of the injection onwards, would they expect to experience much discomfort? When would that usually sort of, if they are going to, when would it wear off? And also return to activity. So what would be your sort of general guidance to people and what they're going to experience there?
Yeah. So, I mean, spinal injections, like any injection, is not the nicest thing to have. It's uncomfortable at the time. We try to minimize that by using local anesthetic mixed with the steroids, so the pain relieving medications, and that often reduces the immediate pain discomfort, even though some will inevitably remain. Immediately after the injection, usually in the first 24 hours, I generally advise patients to take it easy. So relative rest, it'd be best to take the rest of the day off work and not have any activities, particularly strenuous activities planned for the rest of the day, because it's just going to flare things up and make the patient more uncomfortable. So rest in the first day after the injection. And another thing to bear in mind, you shouldn't be driving. So if you have an injection in your neck or in the lower back, you shouldn't be driving on the same day. That's important to bear in mind when you come to the injection. If you come from a long distance, you should really either be coming with a taxi or with someone accompanying you. That's really, really key. That I've been quoted a few times in that situation in the past. And on balance, you want to minimize minimize the risk. So if they're driving home, you want to make sure they can drive home safely, and a spinal injection is not the best way to ensure that, at least in the first 24 hours. But after the first 24 hours, it's pretty much, returning to normal activities as much as you can. In fact, when the pain starts improving, that's really the key time to go back to the exercise program that perhaps your physiotherapy has given you, and ease yourself back into the physical activity, sports, or exercises that you enjoy, because that's actually part of the treatment. An injection on its own can only take you so far. The treatment for neck, back pain, sciatica, etc. It's always an injection plus a good rehabilitation and exercise program. That's really, really paramount, and I always try to emphasize that when a patient come and see me in clinic. The other point to bear in mind, particularly in the first few days after the injection, is that the injection may not work straight away. Yes, the anesthetics that are used at the time will work for the following 4 or 5 hours or so, but after that will wear off, like after having seen a dentist. The same principles apply with local anesthetic. The steroid, which is the painkiller medication that we often use in those procedures, takes time to work. On average, I say it will take about a week to start kicking in. So it's important that patients are aware that in the first week after the injection, they may not feel, a huge change or no significant benefits. And it's a matter of being patient and wait for them to happen. The steroids we use are long-acting, and they take weeks to activate, and they work for months. So it's important that people are aware of that when they come to clinic. And the other thing to bear in mind with steroids in particular, it's an effect or with steroids in particular, it's important to bear in mind the steroid flare-up effect. This doesn't happen in everyone. It happens about 10-20% of patients, but it's a situation when after the injection, the pain actually flares up. Usually it lasts a couple of days. It's more common in the first 48 hours, so the first 2 days after the injection. And when the patient may actually feel the pain is slightly worse, and that's not unusual. It's nothing generally to worry about. It may take some painkillers to take the edge off it, but it's something that happens in about 10-20% of patients. So again, it's something I would always inform the patient to be mindful of, without worrying them, because again, it doesn't happen in everyone, but if it does, it's something that can be managed effectively with simple analgesia and painkillers, and it will settle naturally over a few days.
Excellent. That's a really important one there, I think, because we get asked this a lot. So with the spinal injections, is there any painkillers, any sort of common painkillers that they can't take alongside these injections?
There's nothing specific, but I would always err on the side of caution. So whenever you need some painkillers, for example, to troubleshoot a steroid flare-up or some discomfort at the site where the injection occurred, I would always start with simple analgesia. So the first port of call is something like ibuprofen as an anti-inflammatory, or paracetamol, or if the pain is quite severe, both of them together as a combination. I generally tend to stay away from stronger painkillers like opioids. So you may know things like codeine, codidromol, tramadol, etc., because they're quite strong. They can make you drowsy. They have a lot of side effects, and actually, when used for a long period of time, they make the pain worse because they cause opioid hyperalgesia, which is a paradoxical effect where prolonged use of those pain medication actually makes the pain worse.
Excellent. Another question that we get asked a lot, and I think this is because oftentimes people are having injections because they want their pain to be reduced for a specific event, like a holiday or an important life event. So anything that patients need to be aware of in terms of flying are going on an aeroplane after these injections, and how long before they're due to fly would you normally recommend for them to have the injection?
Yes. I mean, having had the injection doesn't significantly increase risk, for example, of DVT, so clots in the legs and things like that. So it's generally safe to fly after an injection. But again, for as a precaution, I would normally recommend to avoid flying for at least 48 hours after an injection in the spine.
Excellent. And that's just to allow for things like post-injection flare and this kind of thing, yeah?
Correct. Yeah,
Yeah.
you don't want to, have an injection, then the following day flying, and you're in the midst of a steroid flare-up, which you're struggling to manage. It wouldn't be a nice experience, and so which is why we always advise 24 hours of rest after injection. Take it easy. Have some painkillers at hand if needed, and yes, don't fly unless it's necessary for at least a few days after the injection.
Excellent. And what about returning to their usual activities? It might even be returning, I'm thinking whole range here, so returning to normal activities, returning to work, returning to sport. How long do you normally get people to sort of like build up to those things?
It's a good question, but it's actually a difficult question, because the short answer to that is that it depends. That kind of advice has to be individualized to the patients. There are some patients that have an injection, they have no underlying, structural concerns within the spine, so there's nothing I'm worried about in terms of their discs, their nerves, their bones, etc. And I'm happy for them to return to whatever they want physically, whether it's work or sports, as soon as pain allows, so literally within a few days. There's some other patients where they're maybe more frail, they're more deconditioned, so they're weaker because of the pain and the effect that has had over months or years sometimes. And then you have to advise a much more gradual return to activities. And it also depends what they want to go back to. If their main goal is just to walk to the bus stop, to the train station, to work in an office where the physical demands are less, you really go back in a few days at most, and there's no specific timelines for that. It's very much whenever they feel ready, which is usually a very quick time. If they have to go back to sporting activities, particularly at the high level, you want to make sure that a clear plan is in place, and you often need to coordinate that with their coach or physiotherapist or a doctor if they're under the care of another physician.
Yeah, excellent. And that was going to be my next question, really. And that was, a lot of our patients will be probably seeing already a physiotherapist. They're in too much pain to engage in the rehabilitation. They're not really able to make progress because they're in so much pain. But again, that's something that you would sort of talk about on a sort of case-by-case basis in terms of when they should resume with the physio, yeah?
Absolutely. But I'm always happy when a patient comes in and already have been seeing a physiotherapist or are scheduled to see one, because that's really key after a spinal injection to make an ongoing management plan. The treatment doesn't stop at the injection. Sometimes actually is the start of the process, and it's really key to work with a physiotherapist to help someone recover from their pain from the injection and really do the right type of exercises that they need to strengthen their back, neck, or whatever the issue is, because also that's really key in preventing the problems coming back in the future, and it reduces the chances of them needing another injection in the future, which again is not something that we would recommend. We want to do as few injections as possible, and it's really key then to achieve that by doing good quality physiotherapy or exercise afterwards.
Excellent. So really seeing this as a part of a whole treatment and management program or package of care, and really sort of, again, it's this whole creating a sort of window of opportunity for the patient to potentially really make sort of progress with their overall sort of management, which again, I think that's really, really important that you've underline those points. I think that's really, really excellent advice. So, thank you so much for you giving your time today. It's been really, really interesting and educational to hear all about your background, these procedures, how this all works. Of course, if you've got anyone, if you're thinking about whether or not these injections might be appropriate for you, you can contact us in all the usual way, 0207 482 3875, or email to info@complete-physio.co.uk. If we've got any sort of particular questions, we can always be contacted by one of our clinical directors. And indeed, we can always ask Dr. Matteo Bernardotto if there's something that specific that we need to ask of him with regard to a particular patient or particular procedure. So it's a fantastic resource. Thank you so much again for coming along today to talk to us and explain all about this very unique service, I would say. Been great talking to you.
It's been a pleasure being here, and thank you very much for inviting me.
Thank you.